بسم الله الرحمن الرحيم. أعزائي طلبة سنة 6. This presentation is about clinical examination of a lump as general. Subject to be covered in this presentation will be first history for a pain, taking history for a lump, and lastly details of examination of a lump. General rules. Your behavior and appearance is very important. You have to prepare yourself. You have to wear a clean, tight, iron clothes, white coat, and shave your beard, or even make it polite. Cut your hairs. If you are a female, don't wear brilliant colored clothes or excessive jewelry. You have to wash your hand before examination or wear gloves. Tell patient your name and position. This is very important to get confidence of the patient. Get patient permission for taking history or examination, but this is considered as an oral consent from him. Respect privacy of the patient. Don't expose any part of the body of the patient in public. Try to cover the patient as much as you can. At the end, don't forget to thank the patient for his help. Guidelines for history taking. Questions should be open-ended. Encourage. Don't ask questions which have the answer of yes or no. Guidance of conversation but not restricting it. Let the patient speak, but if he tries to speak outside the goal of the history-taking conversation, try to limit him. Clear and specific questions, and ask about one thing at a time and wait for the answer. Cover various aspects of the diseased organ. For example, if the patient complaining of upper GIT, ask about vomiting, cachexia, dyspepsia, and various things. Direct questions may be required sometimes at the end of the history taking. Patient symptoms in his own words as a complaint. This has to be explained to all of you, because it's not that what the patient say will be written, but this frame or phrase is put to prevent doctors who know more information about diseases, prevent doctors from adding any complaint which is very common in the condition of the patient, but the patient didn't say it. I will repeat it again. This phrase is put to prevent doctors from adding any common complaint which the patient did not say. Let's start with the history of a pain. In details, we will ask about the site, localized or diffused, duration, since how long the pain is, onset, how it started, the course since it started until now, type of pain, constant or in attacks, severity of pain, aggravate and relieving factors, and lastly associated symptoms. We will discuss every point in details. First, the site. Indicate the source of pain primarily, and you have to ask if the pain in this area only, or it started in another area and spread to that one now. Point of maximum discomfort that should be pointed by the patient on himself. For example, this lady has a pain in the neck, toothache, shoulder pain, and this is a headache. Another example of the importance of the site of the pain: the abdomen has a lot of organs, and all of these organs could cause pain as seen in these figures. But if you divide the abdomen into quadrants, and if you ask the patient precisely which part of your tummy is hurting him, he will point it to a point where you will transfer this to that pain is coming from special organs. For example, in the right iliac fossa, appendix, and cecum, in the left hypochondrium, spleen, colon, and left kidney. You can have a look on this diagram which show each areas and each part which goes pain by. Mode of onset. What's meant by onset? Onsets mean a duration, a time between complete health condition and full picture of the disease. This time could be seconds or hours or may even days. So we divide onset into sudden, acute, subacute, chronic, and insidious. Sudden, the full pictures of the disease happened within seconds. Acute, it comes in hours, started for example in the morning, and full pictures come at night. Subacute variable, and subacute is usually a disease of internal medicine, not a surgical disease. Chronic take weeks or months, like hepatic fibrosis causing splenomegaly and etc. And lastly, insidious. And the insidious is very common in surgical field, which means undetermined. When a patient comes to you with a very huge goiter in his neck, and he said to you, I noticed it yesterday. Obviously, it wasn't there suddenly yesterday, but he didn't notice it except yesterday, and this is called insidious or undetermined. And this onset usually come with painless lump. Insidious onset cannot come with painful lump or lump which cause pain. What about the course? Now the patient has a full picture of the disease. From this point, is the pain increased or the pain decreased or the pain stationary for hours or days? And also if it's come and go like intermittent course. Also, increasing of severity is either slowly increasing or rapidly increase. What about severity of pain? You can ask these questions to know the severity of pain the patient has. Does it stop the patient going to work? Does it deprive the patient from sleep? What he will do to stop pain? Just lie down, just sit up, or he take some medication? What type of medication, injection or oral? Usually we divided the severity of pain either mild, moderate or severe according to patients' answers about these questions. This is a chart which we use usually for some patient to let them point which degree of pains had. And it's very important when you follow up a patient, especially in post-operative period, when he said to you that the degree is decreasing day by day, he is going in a good way. But if he said that the pain increasing or something, this is something wrong is happening. What about type of pains? There is a very varied type of pains, and each type of pain is indicating some disease or some pathology, as we will see now. If it's stitching pain in Arabic like shakshaka or naghz, this is inflammation of serous membrane. Example of it, acute appendicitis. Inflammation of parietal peritone, which is serous membrane, causing stitching pain. Burning pain, حرقان. This is indicate inflammation or irritation of mucous membrane. The most common burning pain you feel is heartburn, حرقان فم المعدة, or in dysuria because of inflammation and irritation of urinary bladder mucosa. Colicky pain. This means a cramp of smooth muscles and relieving of it in intermittent way. And it's characteristic of a pain from a hollow organ with a smooth muscle in its wall, like small intestine, like ureter, like biliary tree. These all cause colicky pain. Throbbing pains mean in Arabic نبح أو ضبح أو بينبح عليا. It is a characteristic of a pain due to tense pus in an abscess, because this pus usually has a tenderness, and any artery which is going beside this pus by its pulsation will give a fine intermittent tenderness, which the patient explain it as throbbing pain. So throbbing pains mean pus under tension. Stabbing pain, very severe, deeply pain. واحد بيذبحني، واحد بيضربني بسكينة. This is a pain of ischemia. Example of it: cardiac attack, ischemic heart disease, or cardiac thrombus. Severe pain. Electrical pain, like كهرباء في ايدي. This usually due irritation of a nerve by either infiltration by tumor or pressure by nearby swellings. Sewing pain, نشر أو ضبح. It means there is a pathology in the bone or cartilage. Usually the old ladies said that my knees are sewing, بينشر علي. Last type of pain is dull aching pain. It's not characteristic by anything, it's something painful, I cannot explain it. Most of the organomegaly, stretching of the capsule of organomegaly, like hepatomegaly, splenomegaly, causing dull aching pain. There is another type of pain which is not really pain, but it is stretching or heaviness. Heaviness due to splenomegaly, for example. This is caused by stretching on ligaments which hold the spleen down. Exacerbating and relieving factors of pain. Some pains is relieving by lying forward, characteristic of acute pancreatitis. The pain is increasing when lying down and relieved by leaning forward. Some movement like lie flat or about foot montation will relieve the pain, especially of this lady with dysmenorrhea. Some food exacerbate pain, and some other pathology, the pain is decreased when he is fasting, like in the peptic ulcer of the stomach and peptic ulcer of the duodenum. Vomiting and defecation sometimes relieve pains. What about radiation? What's meant by radiating pain? Radiation of the pain or radiating pain is the extension of the pain to another site while the initial part is still persistent of pain. So the patient has a pain in the initial part or initial point of the diseased area, and also he has a pain in a remote area continues with it. Common example of it is sciatic pain, which is a pain due to prolapse of intervertebral disc. The pain started in the lower back and radiating downward along the leg until the ankle. But the referred pain is another thing. The referred pain is the pain is felt only at a distant area from its source. The originating area is not felt at all as a painful, but there is a pain in a remote area. The explanation of referred pain, you studied it before, it is due to a common insertion of the painful or sensory nerves from the deep organ and superficial skin at the same or nearby areas in the vertebral column. So if the pain was from a deep organ like from the heart or from the colon, the brain is described it as it came from a different area, which is a skin supplied by the same neuron. Usually during development of fetus, this skin is migrating away from an organ, and the organ is migrated also out or rotated as GIT rotation in a different way. Examples of referred pain. Most common example of it is the acute cholecystitis, which causes pain in the tip of the right shoulder. Heart ischemia, which is causing pain in the left arm. All these areas in the superficial area of skin is referred pain from a deep organs. A very common example of shifting of the pain is in acute appendicitis, where the pain is starting at or around the umbilicus. This is because the umbilicus is from the midgut, and the originating the midgut was in the midline in the mid part of the abdomen. So the skin supplied by the same vertebral segment is around the umbilicus. This is the skin, and the appendix is moved downward and to the right to lie in the right iliac fossa. So the starting of the pain of the appendicitis is as a referring pain around the umbilicus. But when the inflammation of the appendix is increasing and the parietal peritone near the appendix itself started to be affected by inflammatory process, this make the parietal peritone have the upper hand of giving a sensation, and the pain is localized at that point on the right iliac fossa as an irritation of parietal peritone at this area. We finished a history of a pain. Secondly, we will speak about history of a lump. First, we will ask about the site where the lump is and since when the patient could feel it. Onset, course, it looks like the same as in the pain, but in different way. We will explain it. Persistent of this swelling or intermittent. Does the patient feel this swelling all the time, or he feel it sometimes and not all the times? Lastly, associated symptoms, aggravated and relieving factors which cause this swelling to appear or more prominent when happened. First, site of a lump. We have to differentiate between areas. For example, a lump in a neck is not enough as a medical student or a medical description, because the neck is a very wide area and including a very large number of organs and structures. So we have to precisely mention the site of a lump. Does the lump is in the front of the neck, like in the thyroid, or it is in the lateral side of the neck, it is a lymph node, or in the back of the neck, right side, left side, upper part, lower part, etc. Lump in the breast with its differential diagnosis as it has a benign and malignant lesions at that area. Lump in the skin or subcutaneous tissue, this definitely sebaceous cyst because it has a punctum and fixed to the skin. And in the abdomen also, we cannot say he has a lump in the abdomen or a pain in the abdomen. Abdomen is very big. You have to be very precisely upper abdomen, lower abdomen, central part, left side, right side, etc. Persistent or intermittent swelling. For example, thyroid is usually the patient or the female has a lower front of the neck swelling since long period. But sometimes this swelling is increasing in size rapidly because of hemorrhage or something. The commonest swelling which causes intermittent appearing of a lump and disappearing of a lump is a hernia. Usually the patient come to you say that I can feel it sometimes, I couldn't feel it, and I couldn't find it in other way or other time. Mode of onset. You remember the onset, which is a duration, either seconds or minutes or hours. Here, if the lump appeared sudden, usually it's due to trauma or vascular rupture or vascular catastrophe. Acute is a characteristic of inflammatory process. Any acute lump is a characteristic of acute inflammatory process. Intermittent onset, which means it's happened sometimes and it's appeared at other times, it is indicating it's a hernia. Chronic means that the onset was during months. Here we are dealing with usually a benign neoplasm, and if it is insidious, that's to say the patient sudden without any notice, I will not say sudden, because sudden is a trauma. he noticed it with a big size in a one point very recently, this means it's malignant in most of the time, especially when we remember that insidious onset is accompanied with painless lump. Course of the swelling. When the swelling appear, what happened until now? Does it slowly progressive in course? This means benign neoplasm. Rapidly progressive in course is malignant. It's stationary, or it's regressing, decreasing in size, which is a character of inflammatory swelling, or it is intermittent. Associated complaint. Some swelling is associated with abnormal bowel movement, like diarrhea, constipation, or blood stools. Some of it is associated with difficulty in movement, causing limping in a big swelling of a lower limb, or inability to use hand in a big swelling in the elbow or a forearm. Also abnormal urinary function, sometimes because of the part of your bladder presented in a huge inguinal hernia, causing hematuria, dysuria, frequency or retention, and a lot of examples of associated complaints could be told in this area. Aggravated or relieving factors. Is this swelling become prominent due to special situation or action, or disappeared in another way? For example, standing, walking, and coughing increase the swelling. Usually it's a hernia. Standing increase it, it's a varicose vein. Walking increase it, it's due to effort or something. Lying down decrease the swelling or increase it. Micturition does increase it or decrease it, and eating causing the swelling to appear or disappear. Now we'll speak about examination of a lump, which is the main concern of these lectures in details. We start with the general examination of the patient. Although if he has localized lump or something, we have to get comment about the orientation of the patient, body build and the nutrition. As we see in this picture, we notice that cachexia of this man, paleness or jaundice, which is noticed in the eye of that lady. If the patient has other swellings than he is complaining about, we have to full chest examination and also abdominal examination, especially looking for any organomegaly or other masses. Localized examination of a swelling needs good wide exposure of the area the swellings lie on. First, we will comment about number. Usually, if we say we have a swelling without the letter S, this means it's one. If we said I have seeing a multiple swellings in the back, this means it's multiple. Site of it precisely. Precisely means that swelling in the upper part of the upper medial aspect of the left thigh. Precisely. And also we have to comment about the size. We have a huge swelling, sometimes moderate size swelling, small swelling, but usually describe the swelling in centimeters in figures. Shape of the swelling. The swellings in surgery is either rounded or spherical, it's the same description, or it's oblongate or oval in shape, and the third one is irregular shaped swellings. We don't have any other shapes, either spherical or rounded or sphere. This is a one, or oblong or elongated, and the last one is irregular. We can describe the shape by seeing if its border is well defined as in the upper picture or ill defined as in the lower one. Surface of the swelling itself, if it is multiple as in these pictures, the surface is lobulated irregularly, but most of the swellings in surgery has a smooth surface if it's solitary. Skin overlying. We have to comment about skin overlying. In these pictures we have ulcerating area on the upper photos. In the lower left one we have a punctum which is a characteristic and pathognomonic of sebaceous cyst of skin. On the right lower one, we can notice an inflammatory process, redness, edema, glistening of the skin, and this is mostly but with the history. She said that it's painful, and when you palpate it, it looks tender. This is a skin overlying of inflammatory process. Lastly, the surrounding skin around the swelling itself may show dilated subcutaneous veins, may show some pigmentation like cafe au lait pigmentation in this photo. We repeat again the items of inspection: good wide exposure, and then comment about numbers, site, size, shape, borders, surface, skin overlying, and surrounding skin. Then we will shift to palpation of that swelling, starting with superficial palpation, which is done by gentle manipulating of a superficial part of the swelling to get confidence of the patient, see if there is any tenderness overlying that swelling, and then we will check the temperature of the overlying skin of the swelling by the back of our hands. Deep palpation of any swellings, including all the items which we had already described in inspection of the item. We will check these items again, to make sure that it is confirmed or modified the characters of a swelling. This happened usually with the flat of your fingers. By flat of your fingers, you will palpate by gentle rocking movement all the area concerned with this swelling. So if the swelling in the neck, for example, you will palpate by this way all the neck. After that, when you detect the swelling and see that there is swelling only in this area, you can use the tip of your fingers to get more information about the characters of the swelling itself. After finishing repetition of the site, confirming the site, confirming the shape, the size, and all the features which we told in inspection, we added 3 items. That following 3 items couldn't be done with inspection. First one of it is the consistency. Consistency is done with the flat of your fingers to see if the swelling is soft in consistency, firm, or hard. There is no major consistency other than these 3 points. If you said that, for example, you said sometimes rubbery inconsistency. Rubbery inconsistency is subtype of firm. Stony hard is subtype of hard. So it's only 3 consistency: soft, firm, or hard. Don't forget that the soft looks like the lobule of the ear, firm is like your nose, and the hard is like the feeling of your forehead. I have to explain some point here. From English language, if I say I will give you something soft, you think that I will give you something like yogurt or soft drink. But the soft word in surgical field is meaning the consistency of your lobule of the ear, and the feeling of your lobule of the ear is not like a yogurt or a soft drink. It's a little bit firmer, and this is the soft of the medicine. The same explanation can be described for the hard of the medicines. Hard of the medicines is the hardness of your forehead, not the hard of a wood or iron. By experience and by time, you'll concentrate with your head about what's soft, what's firm, and what's hard. The second point, which couldn't be assessed by inspection, is the mobility. Here we have to differentiate between the superficial mobility, which is attached of the swelling to the skin overlying, which could be examined by pinched up test of the skin overlying the swelling. Another point of mobility is the mobility of the swelling and fixation of the swelling to underlying structure like a muscle or bone the swelling lying on. This done by holding the swelling as in the picture, putting the muscle underlying it in relaxation first and feel the mobility of it, and put it in action and check the mobility and see if there is any difference. That means that the swelling is fixed to the underlying structure. Last point of the mobility is the mobility of a swelling within the tissue it arises from. For example, a breast lump. Does this swelling in the breast lump move within the breast tissue? If it's freely mobile, usually it's something like fibroadenoma. It's fixed. If it is, on the other hand, fixed to the breast tissue, it gives a suspicious of malignancy. So mobility again is three parts. Mobility is the fixation of the swelling to the skin overlying it by pinched up test. The fixation of the swelling to deep structure, muscles and bone by put a muscle in contraction and repeat the movement and see if it's fixed or not. And lastly, if the swelling is moving within the tissue it arises from, like a subcutaneous or something or not. Last and third one item which you have to concentrate with palpation and it is cannot be assessed by inspection is the draining lymph node. Draining lymph node is usually the neck region, the axillary region, or inguinal region, according to the site where the lump is. You have to palpate it very precisely, and if you feel a lymph node in that area, you have to describe its characters. Is it soft? Is it firm? Is it tender, hard, or fixed, or something? Another thing, the rules said, if you have a swelling at any area, you have to check the lymph node groups which drain this area. On the other hand, if you are confronted with a lymphadenopathy patient, a patient with lymph node enlargement of a group of lymph node, at this point you have to search for the area drained by this lymph node. For example, if you have a neck swelling, you have to check the intraoral cavity, you have to check the scalp, the ear, the nose, all the area drained by this group of lymph node. Another example, if you have an inguinal lymph node enlargement, you have to check the lower limb precisely and etc. What about fluctuation test? Fluctuation test is a test applied on a swelling to see if this swelling containing fluids or not. Fluctuation test is done similarly as you do transmitting thrill test for the abdomen in tensositis, but in a small scale. So if you have a small swelling, you will put one finger on either side of the swelling, give a pulsation with one finger and receive with other one. And if this positive, this does not mean this a fluctuation positive. It is means half of fluctuation positive, because you have to change the direction of your fingers in perpendicular plane and repeat the test again. If in both direction it gives you a feeling of moving of the waves, you put it with one finger and feel by the other, this means it's a fluctuating and this swelling containing fluids. Sometimes if the swelling is very big, like effusion of the knee or something, you can do palpation test by one hand in a side and another hand in a side and giving the pulsation with one hand and receive with the other. But if the swelling is very small, in these figures we increase the size of the swelling so you can see and understand what's happened. We hold the swelling with one hand by two fingers, giving an impulse with the finger of the other hand from the top of the swelling, and feel the spreading of my left hand by the other hand. If this happened, this means half of the test is done. You will change the direction of your left hand and put it on perpendicular way and repeat the fluctuation on the top of the swelling, and if you feel it in both directions, this means it is positive fluctuation. This test for small lesions is called Paget test, and it is modified method of fluctuation test. You have to do some special tests in swelling in different area. For example, swelling in the lower part of the front of the neck, you have to ask the patient to swallow and see if this swelling is move with swallowing by inspection and confirm it by palpation. If a swelling is suspicious to have to be a hernia, like in these pictures, you have to ask the patient to cough and see if swelling has a characteristic of impulse on cuff. This mean expansion of the swelling in all direction during cuff. Also, if a swelling in the limbs, like in the knee or lower limb, you have to palpate the distal area of this swelling to see if there is a local effect of this swelling, as decreasing blood supply or decreasing pulsation, a decrease, a change of the skin of that area, abnormal sensation or something which is causing by this local effect of the swelling on a lower limb in this picture. Percussion. Percussion overlying the swelling itself is good, and it's applicable if the swelling is large enough to do, and you will describe it as a resonant or dull. But please don't forget that sometimes you need percussion away from the lump, like you percuss on manubrium sterni to make sure that this thyroid or goiter enlargement is not retrosternal extension. You percuss on all intercostal spaces to see if the splenomegaly, you feel it on the abdomen, is upper border is higher up in the chest or not. You percuss on an abdomen and feel if there is a resonant abdomen due to obstruction by a swelling or a lump in the left iliac fossa for cancer colon. Sometimes you will check for shifting dullness in the abdomen to detect if there is ascites or not. So percussion is overlying the lump, as well percussion on nearby area to see if it is give you some more information about the lump or not. Auscultation of a lump, it has little role in surgery, but don't forget to do it. You have to auscultate if you find a bruit or vascular bruit. This means this swelling is vascular, either aneurysm or fistulas. Also, don't forget to auscultate the chest clearly to see if there is a secondaries or something, especially if you are dealing with a malignant swelling. Finally, summarize your finding. Put a positive points you find in details. Prepare next plan what you will do, what you will prepare for this patient, what investigation you ask for each patient to reach the final diagnosis and good management of each case. Finally, thank you for your following these lectures. I wish all of you all the success. Any inquire, you can contact me through the email. Thank you again.